Thank you very much once again, Mr. Lakani. This is one case, one pearl. Some of these cases you would have already seen, but I'll try to go with a lot of patience and highlight. Now, this is the patient of Porphyro-Petit syndrome, a 62-year-old female with double vision, right periorbital pain, and blurred vision of 6 months duration. She was diagnosed to have thyroid eye disease elsewhere and treated with IVMP and oral steroids. But after that, she developed drooping of the left eye. And she was systemically, she only had hypertension. But she had this pulsatile lesion in the neck. I hope you can see this visible pulsation. Now, the scan showed thickening, gross thickening of the right superior rectus, but not typical as that we would see in a lymphoma case or a thyroid eye disease case. But this I would still attribute that it is thyroid, because on the other side also some of the muscles were thickened. Usually it's not common to see lateral rectus, but this is all what it showed. The gross thickening of the superior rectus on the right side with some amount of other extraocular muscle thickening. So because of this pulsatile lesion, I knew we are not dealing with a straightforward case of any tumor or thyroid. So we wanted to get her systemic evaluation done. A CT aortogram was done, but there was not gross aneurysmal dilatation of the arch of aorta, which we thought would be there. But there was ectasia, that is some amount of dilatation of the brachiocephalic artery, right side, aortic arch, left common carotid, and the vertebral artery. So this, what was it causing? This was causing the irritation of the cervical sympathetic chain on the right side. And on the left side, she had developed some features of Horner syndrome. My colleagues in the endocrine department said that right now her thyroid function tests were normal and the antithyroid antibodies were also normal. But the vascular surgeon also suggested that nothing to be done for the ectasia except just change the antihypertensive medication. Neurosurgeon wanted to do a superior rectus muscle biopsy, that is before he saw the CT aortogram. So if I had done that, I might have burned my finger because I would have had severe uncontrollable bleeding on the table. So in this case, we only watched and her symptoms gradually elevated, though the pulsation didn't go off. We just told her the problems and no surgery was done on this case. So the important take-home pearl is link ophthalmological and systemic findings to the best extent possible. And this is a 43-year-old woman, the next case, protrusion of the left eye with blurred vision, and a very recent history of hypothyroid status, diabetes mellitus, hypertension, and raised serum prolactin levels. So she was having multiple endocrine dysfunction. So features suggestive of a pituitary dysfunction clinically also, because she was quite a tall lady, almost 6 foot in height, and had features of hirsutism, etc. I'm sorry, this should have come earlier. How we link systemics in thyroid cases, gross anemia, other autoimmune diseases like pernicious anemia, vitiligo, myasthenia can be seen. So this slide has come in between. Now coming back to this 43-year-old lady, she had good vision in the right side, mild blurring on the left side. Notice the thyroid swelling in the neck. Now the MRI confirmed features of the muscle thickening on both sides, slightly more on the right side. But what else did we see? Now this particular lesion in the pituitary area, it was a sphenopetroclival lesion. So 3 bones were involved here and the lesion was sitting here and was causing all the pituitary dysfunction due to multiple endocrine problems. So again, going back to the anatomy, a very typical area where the meningioma sits. So sphenopetroclival lesion. Now she had some amount of field changes. Now the management is, are we just going to watch this lesion because day by day her symptoms were increasing, or do we surgically excise, or just there's no chemotherapy as such for meningioma per se. But of course, a lot of talk of cyber knife and gamma knife now. Cyber knife is the mainstay, though gamma knife has also been employed. It's actually for those of you who want to just think a little more, it's nothing but a little bit of interplay and change in the LINAC, that is the linear accelerator. Some of the settings are changed. But of course, then these machines are so expensive, the treatment costs also become expensive. But for meningioma, CyberKnife is something which will stay. We don't have to do surgery because we know invariably, even if they have good vision, they will lose their vision. The chances of losing vision on the table very much is there. So in this case, the neurosurgeons felt that only a radiation would not help. Let us partially debulk some of the lesion, and the remaining part will give her radiation because it was a meningioma grade 1, and the size, according to them, was a little big. So she underwent surgery followed by radiation. Now she's on a 4-year follow-up. Initially, she had a little bit of abuse, a 4th and 6th nerve palsy because of the location and the surgery. She has residual lesion, which has been taken care of radiation. And this is her 4-year follow-up now, wherein she is doing very well and maintaining good vision in both the eyes. So once again, coming back to meningioma, where I speak about gamma knife, in such cases where a biopsy, very straightforward, this is a meningioma, the typical tramp track appearance, surrounding and encasing the bone, straight away go for a gamma knife instead of subjecting the patient for surgery. This patient only had a little bit of periorbital puffiness with a little bit of dip in vision. So this is her serial. This is February 2017, the papilledema, opticociliary shunt vessels, which we see gradual decrease after the gamma knife treatment was given, February 2018. This is August 2018. After that, she tells me she's doing well. I'm yet to see her for a follow-up, but she is maintaining 6/6 vision in her right eye. Now, after the treatment also, there will be a little residual lesion, but that can be carefully watched, because some amount of it would have already scarred. So the take-home point is, for meningioma, gamma knife is the treatment. It is available in certain centers in India, and it is worth the cost at the moment, and we hope that it can be brought down. 2-year-old male child, there's a sudden onset of proptosis after an upper respiratory tract infection, lesion closely pressing on the optic nerve, and you can see in close proximity to the nerve. This is a very cranky tumor. Many of you have already guessed it. After an upper respiratory tract infection, it likes to hug and wind around the nerve. CT scan was also done to see whether we could do an FNAC, but 2-year-old child, you will have to give GA. Then you will wonder, why not do surgery itself rather than do FNAC with its risks. So here, a course of IV steroids is given because in lymphangioma, there is certain amount of lymph inflammation. You should realize that lymph cells are not cells which are typical for the orbit. They are some kind of rest cells which are there, that is normal cells in an abnormal location. So usually inflammation triggers this tumor, and it's a very bloody and vascular tumor. So steroids were given to bring down the inflammation. Many a time, pubertal age, they get a second attack, and it increases grossly during puberty. So here, what do? Do you observe this lesion? It's pressing on the nerve there, because 1 month later, the child was still a little uncomfortable, symptomatic. And you can see the lesion has slightly actually become bigger, and it's pressing on the optic nerve. Almost half the nerve has got compressed there. So repeat a course of steroids, which is not great for a child, because again, you have to admit the child, or needle drainage, FNAC, or a surgery. In this case, we went ahead with the surgery, a lid crease approach for the superior orbit, which is my favorite. I don't like to make any brow incisions as much as possible because it leaves behind scars, and the child improved. So suspected lymphangioma, when there is sudden onset of proptosis. Of course, in the last 10 years, sclerosing agents have helped us a lot, especially bleomycin. We tried many things, picibanil, that is OK432. We tried a lot of triamcinolone. All of them have about 50%, 60%, but bleomycin, I think, is working very well. It's here to stay, except for a violent reaction. In this child, I had not yet started using, but again, we have to see the safety in children and be very careful and judicious while injecting. We partially debulk and partially, but especially when it's posteriorly located, I think the residual cyst can be taken care of with the help of a sclerosing agent, because as you know, lymphangioma cannot be removed fully. Now, this was a child, 12-year-old child with a lesion, which is we call as a triradiate lesion, and there was protrusion of the right eye, which was only recent, loss of weight, loss of appetite, feeling unwell. Now, this lesion is there. You can see it in the intratemporal fossa, lateral orbit, sitting there. Some erosion of the bone has already occurred. You must think of malignancy because of recent onset and loss of weight. But again, you have to keep everything in mind. So here, I don't think we offered any trial of any treatment straight away. She was admitted for surgery on the, and so the possible diagnosis was tuberculosis or other granulomatous lesions, a malignant lesion because of erosion of the bone. Again, TB can cause erosion of the bone, or a dermoid, which is very unlikely because the presentation was quite dramatic. Intraoperatively, there was thick purulent material with granulation tissue. And of course, she turned out to be manto positive. The good thing is we already knew about gene expert test, because TB to demonstrate in the Zeal-Nielsen can be done, but many a time it's negative. Again, cultures take a long time, just like fungus, which we are all facing now. So manto test was grossly positive, but the gene expert test, which usually comes in within 48 hours, is very, very helpful. Here, you don't have to put the sample or the tissue which we take in formalin. Straight away, we subject it for the gene expert test. I think it will be available in almost all the major cities and towns in India. And she was on ATT. Then what happened? About 3 weeks later, she comes back. She was improving. She comes back with drooping on the other eye. So a little bit of the pus, which could not be drained, had trickled along the chiasm, please note, and gone to the other side. I've seen patients of my husband's who have had silicone oil trickle like this. And that too, especially if they've lost vision and on one side, this can be pretty devastating. So please keep this also in mind. And you need not waste time in doing a fields, but if you have time, you can do that. All here it needed was a little change in the combination of our anti-tuberculous treatment. And generally, ATT has to be given for a little longer time in such cases. Now, sometimes they are not so lucky. They start having a sequestrum with a discharging sinus, some amount of ulceration. When sequestrum comes, this has to be debrided, especially in tuberculosis cases. So common things common. Of course, you have to keep malignancy topmost on your mind, but a careful history and clinical evaluation and keeping other tests handy like your manto test, gene expert helps. Now, when you have cases like this, trauma, acute cases, with superior wall fractures, bone fractures, here at least the child was conscious, but if the child is unconscious, generally the neurosurgeons would like to admit these patients in the ICU, and they are under observation because you have to worry about meningitis, whether the child will survive, throw fits, etc. This is called neuromonitoring. Generally, that time the child is not fit or the adult is not fit for general anesthesia, and we would like to observe. In this particular case, there was a fracture in the superior wall, which the neurosurgeon said need not intervene. When you have a fracture like this, look carefully for CSF rhinorrhea. And here, when you have devitalized tissues, you think there's still not much of necrosis, don't be aggressive. Just wait, be patient, and you have to observe these cases. IV steroids, antibiotics for the first 48 to 72 hours. As steroids, generally the neurosurgeons or the others and ICU specialists, internists are not forthcoming, but please request them, work closely with them. Luckily, Muker has taught us all to work closely together. And immediate surgery with consent for evisceration, please don't do that. Just wait. Once the child is stable, a week later, this is how the child improved. This is 2 weeks later and a month later. So don't be aggressive, especially with fractures in children. They behave like typical Greenstein fractures. Now, if the eye is quiet, typical diplopia, this is within 48 hours, then you know there's not much of edema, then you know you have to intervene. But please look at all the general condition, neurostatus, wait for about 1 week, 2 weeks, let all the edema subside. That's the general teaching in fractures. Then take up the patient for surgery. So it is better to be conservative. Now this dengue case, which I saw some time back, it's also been published. Now he had 5 days fever, and following which he was given platelet transfusion. Then he developed acute loss of vision, high intraocular pressure and orbital pressure could not, and he was transferred from another hospital in this state. could not retract the eyelids, highly elevated IOP, platelets were very low. It was around 7 to 8,000. He was in a delirium state, blood staining of the cornea. That was after a few days later, I noticed. So when I could take him up, about 2 days later, I could take him up under GA. But this was what I found. The cornea was fully necrosed, means it had become fully black, because blood staining itself of the cornea takes about 1 week to 2 weeks. But here it had become totally black. And I did a lateral canthotomy and cantholysis. The left eye started auto-eviscerating by then itself. So I didn't do anything much. I just held on. Right side was subsequently, he was taken up by for a PK, that is tectonic PK, but completely there was necrosis inside, white. The vitreous was white, the retina was white, the optic disc was pale, and this he had all along a bleed along the perioptic sheath. So this was another case of dengue. He was in the ICU. He had cerebral infarcts, but about 6 days later developed the eyelid edema. He had an infection. He had endogenous endophthalmitis due to dengue. Now the question arises in dengue cases, should we give a high dose of immunosuppressives? Because that same question is arising now for COVID cases. Should we give a high dose and prevent the immune reaction? Because all this is a kind of an immune reaction. Unfortunately, in this case, I had to eviscerate one side. Luckily, the other side was absolutely normal. Now, immunosuppressives can be, but the disease itself, we don't know. The other things have to improve. And in the long run only, we'll be able to say whether what happens to these immunosuppressives, how do the patients respond. Now, we see very often eyelid tumors, that is sebaceous gland carcinoma. The importance of biopsy for these cannot be overemphasized. This patient came to me sometime in 2014. About 7 or 8 years earlier, he had a tiny lesion in the lower lid, and it was biopsied, and he was told it was just something like a chronic granulomatous inflammation, and he just slept over it because he knew that this was from a very big hospital which had given him a proper biopsy report. I think sometimes this can happen, that is to all of us, that if we have to go deep, if the patient, if the doctor had gone in a little deeper, they would have found this to be a sebaceous gland carcinoma. So here you see it is almost invaded half the orbit. So what was essentially an eyelid tumor had become an orbital tumor. He was not willing to believe, he didn't want. And then we did a DE biopsy. Here you will notice that I have gone up to the bone, and it was confirmed. And then he didn't want exentration. So an excision was done under frozen section. Adjuvant chemotherapy along with radiation was given. But despite all heroic surgeries, he used to have repeated corneal inflammations because the radiation has its own side effects, radiation, corneal changes, surface changes, retinopathy, etc. And then he was, after about 5 years, this was the situation. Finally, I said, okay, he's disease-free now. Cornea is getting stable with, in between, BCL also could be used for a short while, but then it used to fall off because of the lid condition. So this was so bulky. And then I tried to do a phonics reconstruction here. And about a year later, I noticed recurrence in the superior orbit, which was absolutely free to begin it from the beginning. So now the last 2 years, I've not followed him up. But what I mean to say, it's about 11 years of utter misery with sebaceous gland carcinoma, which could have been beautifully taken care of. Now, orbital infections, you have the cellulitis, this is very common when we have sinusitis. Subperiosteal abscess starts behaving like a tight compartment syndrome. Now, when you have orbital infection, subperiosteal abscess, or even orbital cellulitis per se, please remember two important structures of the eye which have to be taken care of. One is the cornea, just like your thyroid disease. You have severe exposure keratitis. You don't want to, in addition, because of the infection, you don't want to have a corneal infection or a corneal abscess. And the next is, of course, your optic nerve, where you want to decrease the morbidity to the optic nerve and prevent optic neuritis. See, another thing is the subperiosteal abscess. Outside, the proptosis may not be very dramatic. But then sometimes with your IV antibiotics, earlier we were giving oral. If it doesn't respond, we used to give IV. But these days we know when it's quite, when the imaging shows quite a lot of involvement like this, you straight away start with IV antibiotics A combination of broad spectrum. I like to add glycosides. By day 2, I give them also steroids under cover of antibiotics with the help of a pediatrician in children and an internist in adults to decrease the morbidity to the optic nerve, to prevent optic neuritis. Because of you may beautifully clear your orbital cellulitis, but you don't want the patient lose their vision due to optic neuritis. So another thing is sometimes this abscess can just shield off and start behaving like a tumor, which is an antibioma, but it's not, it will sometimes even mimic a malignant tumor. So this slide I brought in the other day for our subspecialty. So this is diffuse cellulitis. This is a localized abscess, still has to be carefully imaged and taken care of because it can shield off and become an antibioma. This is a subperiosteal abscess, which can behave like a tight compartment. You see, it starts pushing up and starts creating morbidity to the optic nerve, though outside the proptosis may not be severe. And last but not the least, if the infection is not properly controlled, you can have cavernous sinus thrombosis, meningitis, and can even lose the patient. So why it all started with some sinusitis, which we already have. In Bangalore, 8 out of 10 patients, if you take an X-ray, will have some amount of sinusitis. So here, the best thing is to debride endoscopically. Here, the patient needed both an endoscopic debridement with an ENT surgeon plus an external cut, because sometimes if the abscess is very tense and getting shielded off with fibrous tissue, as I just mentioned, you need an external cut as well. The sinuses should be beautifully opened up along the natural passages. As much as possible, don't make external cuts except when it's absolutely essential. So here a thorough anatomy of the sinus passages is essential. Here again, most of us are orbit and oculoplastic surgeons. Why? Even many ophthalmologists across India have now started closely working with ENT surgeons. In that way, it's a win-win situation for each and every city, every town, and every hospital. But sadly, at the expense of what? Sadly, at the expense of mucor. Anyway, now sometimes midline lesions like leukemia can present as severe sinusitis and orbital abscess. Please keep this in mind. These all come under masquerade syndrome. Again, leukemia is one tumor or chloroma which likes to go along the central lines. Kasuri has a beautiful paper on chloroma, I remember. Now, mucocele, again, frontal mucocele, ethmoidal mucocele, frontoethmoidal combination mucocele. Please make sure the mucocele is drained under the natural passages, if at all one small cut. Because again, this can be very dramatic sometimes. The patient may not know they are harboring a mucocele unless they develop severe secondary infection with gross proptosis. Sometimes there can be severe lead edema. And this is a lady who had about 13 to 14 surgeries. She had about 11 elsewhere before she came. All of these had become encapsulated and loculated with thick fibrous tissue. So initially a FES was done with ENT surgeon and an external cut, but that was not enough. About 2 years later, though she wanted to avoid this, we had to do a cranial surgery, go in, debride. The ENT surgeon had to come in with the endoscope. I had to go and make another cut in the orbit to take off, and debridement was done cranio with a neurosurgeon. All the frontal sinus debris was debrided. Here again, some people like to keep it with fat, but if you can again widen the frontal recess and make a large opening so that the frontal sinus, whatever residue is there, will permanently drain. At the most, we can keep some bone graft, or at the most, we can keep a certain other material, because grafts don't work well due to infection. And sometimes there can be residual defects like this, but that can be always taken care of at the later stage. Now, this patient is on a 4-year follow-up, disease-free. A little bit, this is not the latest photo, I'm sorry. She came early this year. She has a mild proptosis, but that's about it. I would rather say it's a mild dystopia, and she's doing well. So a mucocele should not land up like this. That is the take-home message or the take-home pearl. Now again, coming back to the scourge, which we are all facing across this country. Now this is a 19-year-old boy with 600 sugar, and this was the state. He came for NLD surgery all the way from the from the Gulf, one of the Gulf country, I think Muscat. Okay. Now, what do you see here? This was the involvement. A FES was done, and then a little bit of blackish material came out. So immediately that was aborted. He was treated for mucor. Subsequently, a year later, he had underwent a DCR surgery, because DCR surgery, of course, an endoscopic DCR was done, but some amount of canalicular obstruction had also developed. So this was taken care of later. Then, of course, he lost his weight. He was weighing around 125 kilos. He lost his weight. His sugar level came down, and he beautifully managed his diabetes and his mucor. He has not had a recurrence at all in the last 11 years. This was sometime in 2010. Now, in mucor, what we would like to do ideally is to get a very good imaging done. But all these years, we have been mainly getting CT, because we do FES along with the help of a ENT surgeon. But can I please interrupt here? Can you please request Santosh to come on, please, if he is available?
I'm there already, so you can finish.
Hi, Santosh, thanks. Yeah. Go along the natural passages and debride the sinus. Now, in renal transplant patients and those who are severely immunocompromised due to severe malignancies, or the most common is diabetes, post-renal transplant patients who are on long-term steroids, in fungal cases, you may have to give a little bit of steroids also. But debriding and with this liposomal amphotericin B is a real blessing. And they may sometimes need a little longer, at least minimum 2 weeks of hospitalization with liposomal. Then you can discharge them with posaconazole. I've even given steroids, and this was one success story. Patient is fine and well. He's underwent a cataract surgery also later, about 3 years back. This is another success story where the patient was severe, very high sugars, 400, 500 sugars. Then you also notice this double density sign of the fungus. Okay, yeah. You can know, okay, it's not there in this. Here in this slide, you will see within the sphenoid sinus, a double density sign. This is almost again typical of mucor, because many a time, just like TB, mucor is not so easy to demonstrate. So again, a thorough debridement, opening of the sinus, along with liposomal amphotericin B, depending upon the clinical condition, with the local amphotericin B, you can give the lavage every once in 2 days or once in 3 days, depending. And the patient goes back with a course of antifungals if required. That has been the mantra for many, many years. But of course, we all had to face this mucor by a storm. And supposing a patient doesn't come back for proper follow-ups or really debilitated, then they start developing this eschar and eschar, which we saw in these cases also now during the scourge. And then they tend to auto-eviscerate. But if or auto-exenterate. Now, if I remember in retrospect, in the last 31 years, not had a single case where we had to exenterate, but in this case, it was almost like an exenteration where I had to debride, and most of the time it's necrotic tissue. And once you put in your endoscope, you will see this blackish material there in the middle turbinate, then you almost know it's fungus. And sometimes in the early stages, when there is a very minimal involvement, but already type 3, that is where it has gone to the brain already, where the cavernous sinus involved, you will see a complete bluish discoloration. Everything will be bluish color there. There in that case, please don't do any biopsy unless you see some necrotic tissue, because if you make a nick with an endoscope, you will have severe bleeding, uncontrollable bleeding on the table. This is one case I managed recently. I was asked in called in to exenterate, but I said, hold on, cornea is clear. Let's clean up and see. Again, here you see a double density sign here inside, beautiful double density sign. So one debridement had already been done by the ENT surgeon. Again, we undertook a 3-hour debridement, and this was a active COVID positive patient. And this is day 5. He improved very well. I did a temporary tarsography there just to hold things back. Cornea cleared. He said he was also seeing light in one quadrant. And there was a little, the needle rectus was not behaving that well. But by day 11, this happened. See, he was on local ampho. Unfortunately, we didn't get liposomal because it was severe shortage. And he had side effects to that. Plus, he had some amount of intestinal involvement due to COVID. So he was also developing severe diarrhea because of the medicines, because of the intestinal involvement, but he was already a diabetic. So I can't say that the pancreas also had been involved, because we didn't do any pancreatic biopsy for him. But unfortunately, this patient, by day 13, he was lost. So what I mean to say is, I think we have to just keep everything in open, eyes open, ears open, everything open, to pick up all those telltale signs and learn from each and every case and impart what we know to others. And hopefully, I think now we will not be faced with this kind of a problem again. It's been overwhelming. I thank Santosh. I thank many of the people, those who are present here, who have seen much more cases than me and helped out in bringing out treatment protocols. With this, I end. Thank you very much. Over to Santosh.
Thank you, Lakshmi. I think you covered a lot of ground. Wonderful talk. If you have more slides, you can speak on, because we have 1.5 hours.
No, maybe I'll go in for Manisha's talk, come back.
Yeah.
And then what I will do is we can take some questions, and
Sure.
because I'm sure you will have a lot, and you also in some of your slides you have to rush sometimes because of the shortage of time. I think you can take your time and explain very well, and I'm sure there will be much more to learn from you. In fact, I don't want to miss your talk, but this was inevitable.
Sure, please come back. All right.
Yeah, thank you.
Thank you so much. Good afternoon. I'll be talking about logical approach to orbital tumors. Basically, I'll be covering the tumor part of it. Lakshmi has already covered infection, inflammation very beautifully. So I'll show you pictures as well as talk some theory on each of those. This is a simple classification of orbital tumors: primary and secondary. Primary can be further classified as benign and malignant, and secondary are almost always malignant. This is one more way of classifying orbital tumors based on the etiology. Cystic lesions are not tumors, but they come to an ocular oncologist, so they are there. Otherwise, it's vascular, peripheral nerve tumors, optic nerve and meningeal tumors, myogenic, fibrous connective tissue, osseous and fibroosseous, histiocytic, melanocytic, and epithelial tumors of the lacrimal gland. This is a simple classification. Now, before we start, we should know what is the general frequency of these tumors. In about 1,000 patients, we found that the top 4 are these: lymphoproliferative, could be lymphoma, benign reactive lymphadenoplasm or atypical lymphadenoplasm, vascular, secondary, and cystic. These are the top 4. The next 4 or 5 are neurogenic, inflammation which are biopsied and proven, mesenchymal, lacrimal gland lesions, and infections. Rest of it is all minority. So if you know the relative frequency of tumors in India, then you're slightly better off in identifying what you're dealing with. Let's start with this particular child. Now, this child is born with a mass in the lower orbit, right? So how do you get a clinical clue what it could be? He was born with it, and it is slowly increasing in size. Now the child is about 3.5 months. Before you even attempt to open this eyelid, which is very tensely obscured by a cyst, you can't really pry it open without doing general anesthesia. You look at the other eye. Other eye has triangulation sign. That means that if this is the shape of the cornea, which is normally round, if there is kind of a triangulation, if the corneal contour is altered, it is generally associated with uveal coloboma. So one eye having uveal coloboma and the other eye you see a cyst, that means that it could be an orbitopalpebral cyst with microphthalmus. And that is exactly what it was. It is a bluish lesion. But in the absence of abnormality of the eye itself, such bluish lesions could be teratomas, could be capillary hemangiomas, could even be lymphangiomas with bleed. So you have to exclude all of the possibilities before you come to a diagnosis. So what do you do in such a situation? You simply aspirate the cyst, because you have to prognosticate vision first. And if you feel that there is any visual potential at all, then you can excise the cyst. Or if there is no communication between the rudimentary eye and the cyst, you can inject them with sclerosing agents if there is visual potential. If there is no visual potential, then you still can't simply leave the cyst alone, so you can do sclerotherapy. Sclerotherapy can be done with many agents. No, exactly similar situation. The child is born with this swelling. The other eye is perfectly normal. And when you do the scan, you find that there is an enlarged eye and the lateral wall of the eye is missing and it is merging with the periosteum of the lateral orbital wall. Optic nerve, of course, is present. There is no evidence of anterior segment structures. So this is a congenital cystic eye. In this situation, there is no scope for vision. All you would want to possibly do is enucleation or evisceration and rehabilitate the child cosmetically. The third proptosis in a newborn is if there is abaxial or axial proptosis. This child just born is a teratoma. You have to always consider the possibility of a teratoma in a newborn proptosis, and teratomas can be malignant or benign. And if it's a malignant teratoma, then there is generally involvement of the bone and intracranial extension, periocular hemorrhage, etc. But if it's a quiet teratoma like this, which is in a quiet white eye, you can see a fully grown tooth within it, and there are bony elements within it. This was a benign teratoma, and you have to excise it because otherwise there is a possibility of optic nerve compression and the child losing vision. This is a simple capillary hemangioma of infancy, but with orbital extension. So orbital tumors can also manifest in this manner. Generally, capillary hemangioma of infancy is limited to the eyelids, but rarely there can be orbital extension. This is a rare lesion, intraosseous hemangioma. Here, what happens is that there is a lesion within the sphenoid wing, and you see a large amount of large lesion occupying the temporal aspect of the bone, and also with intracranial extension and also orbital extension. This is a kind of a triradiate lesion centered in the sphenoid wing, and it is hard to palpate. MRI can or CT scan can help you diagnose it, but final diagnosis is always by a biopsy because there are simulating lesions. This can be curated. There is no other medical cure to it. So in children, if you want to classify proptosis, axial proptosis and abaxial proptosis, the most common cause for axial proptosis in children is optic nerve glioma. So if you have a child with unilateral or bilateral axial proptosis, look for stigma of neurofibromatosis. Look at the child for caffeole spots. Look at all other major and minor signs of neurofibromatosis. Look at the iris for Lisch nodules. Look at the entire body surface for any signs of neurofibromatosis. And if you have one, that actually clinically fits in because neurofibromatosis is associated with optic nerve glioma. Of course, ONG can also happen without neurofibromatosis attendant. Now, if there is abaxial proptosis, then you further classify it as subacute or chronic. Acute abaxial proptosis is mainly because of infection, which Lakshmi has already spoken about. If it's subacute abaxial proptosis, there are possibilities: Rhabdomyosarcoma, leukemia, primitive neuroectodermal tumor, alveolar soft part sarcoma, etc. If it's chronic, then it is either lymphangioma or dermoid. Now, in the setting of a chronic proptosis, if there is acute exacerbation, then it is generally lymphangioma with intralesional hemorrhage or because of formation of a chocolate cyst. Now, this is a patient where there is very subtle proptosis. You hardly can notice that there is proptosis of the left eye, but she had squint, because of which her parents took her to an ophthalmologist, and you can see a nice optic nerve glioma there. There's one more child where there is bilateral proptosis, and parents took him to a doctor because the eye was not fixing. There was nystagmoid movement, and you can note that there is mild proptosis of the left eye. Right eye looks normal, but there is bilateral optic nerve glioma. So axial proptosis cause is mainly optic nerve glioma in children, chronic axial proptosis. So this is a child with abaxial proptosis with downward displacement of the eye resulting from a lesion in the superior orbit with superior phonacial fleshy lesion as well. This proved to be rhabdomyosarcoma. So in this situation, you have to keep leukemia definitely in mind. You have to keep lymphoproliferative lesions such as non-African Burkitt's lymphoma in mind. You have to keep other differential diagnoses in mind. Even histiocytic lesions can occur like this, but rhabdomyosarcoma tops the list. In fact, rhabdomyosarcoma is the most common primary malignant orbital tumor in children. This is also an example of rhabdomyosarcoma. It is very vascular. You can see excessive vascularity within the lesion, and even when it occurs in the anterior orbit, you can see large blood vessels which are supplying this hungry growing lesion. So that is rhabdomyosarcoma. Of course, we won't discuss too much about the management here. There's one more child where there is abaxial proptosis, eyeball displaced down with a lesion in the supratemporal orbit, but she also has a subconjunctival hemorrhage. And when we did the fundus evaluation, she had rod spots, etc. So here, your diagnostic consideration is slightly different because rhabdomyosarcoma does not present with subconjunctival hemorrhage or rod spots. It's mainly leukemia that you're dealing with. So you don't have to do an orbital biopsy to confirm the diagnosis. You simply have to do a peripheral blood smear, which will show you these abnormal leukocytes, which confirms the diagnosis of granulocytic sarcoma. Now, this is something clinically you cannot diagnose it. A child presenting with subacute proptosis with a fleshy orbital mass, which is highly vascular, deforming the eye. You can see iso density on CT scan. So you can't really say whether it is rhabdomyosarcoma or leukemia or, for that matter, primitive neuroectodermal tumor, which is a very rare tumor. So on biopsy only, you can confirm all these are round cell tumors. So it's very difficult for the pathologist to confirm one from the other unless they do a good immunohistochemistry. Of course, peripheral blood smear will be abnormal in children with leukemia. Now, this is a patient where there is mild abaxial proptosis, although there is an axial component which is more predominant. The eyeball also is displaced slightly down, and this is a lesion which is centered on an extraocular muscle. That is how typical uh, alveolar soft part sarcoma presents. It is centered in an extraocular muscle. In this patient, it was in the superior oblique muscle, and it can be in the inferior rectus muscle, it can be in the medial rectus muscle. But if a well-circumscribed lesion is causing abaxial proptosis or slight displacement in the predominant axial proptosis and it is in a child, then you think of alveolar soft part sarcoma, which can be confirmed by excision and biopsy. Now, this is a young lady who has slight amount of displacement, but mainly it's an axial proptosis. And she has been having it for several years, and it is disproportionate to the size of the lesion. That's typically lymphangioma. Lymphangioma is chronic, so there is fat atrophy. So lesion grows at the expense of orbital fat. There is not much of proptosis unless they bleed. But lymphangioma can also occur anteriorly in the orbit. You can see a bluish discoloration, multilobulated, what called pseudoseptate lesion with bluish discoloration, which kind of hugs around the eye, does not cause too much of displacement of the eye or does not have pressure indentation of the eye, is orbital lymphangioma. But orbital lymphangioma does not always look as benign as it looks here. It can present with very dramatic features when it bleeds. This child had a small minor injury at school while playing, and then she came with this. So with this clinical appearance, without any prior history of proptosis, you can't simply say what it could be. You have to complete the diagnosis by doing a good radiological evaluation. And then, of course, this child underwent an incisional biopsy, during which time we diagnosed that there was a larger lesion with clotted blood within it, and that proved to be orbital lymphangioma, which always was there, but it was so subtle that parents never noticed it, and it was noticed only when the child had massive bleeding. Now, this is a patient where the lesion is there by birth, but slowly increasing, and this can also be present in the supranasal aspect. This is nothing but an orbital dermoid. Orbital dermoid is either present in the supratemporal orbit, that is external angular dermoid, or supranasally, that is internal angular dermoid. External angular dermoid is more common than internal angular dermoid. But orbital dermoid can also present with various other manifestations. It can be very large like this. All these have typical features in the sense that they are spheroid. They almost conform to the shape of sphere. Some of them may have broader base like this. Like this patient has a broader base, and if they have a broader base, then there is generally periosteal attachment. If you can move it in all directions, then that is a very easy situation for surgical excision. But if it is fixed like this without much movement, that means that it has periosteal or sutural extension. Sometimes it may have even extraorbital extension, or it may have involved the bone as well. In patients who have irregular margins like this with involvement of the lateral wall, getting the entire lesion out is very difficult. Also, in situations like this where the bone is eroded and the lesion is irregular, you have to very carefully do a marsupialization. That means you excise one wall of it, evacuate the contents, and remove the residual lining very carefully. Similarly, if it has a broader base and is fixed to the periosteum, you have to excise the periosteum along with the lesion so that it does not rupture. If it is extraorbital, like this patient has an orbital dermoid with an extraorbital component that is called dumbbell dermoid, you have to cut the bone on both the sides of the lesion like that, do an osteotomy and excise the lesion along with the bone through which it traverses. Otherwise, it can be breached. Now, this is a patient where there is a very small dermoid, but yet you can see that there is a small extraorbital component, and which is very clearly seen. The defect in the bone, which is small, is seen on the CT scan, three-dimensional reconstruction. So in these patients, you have to be very careful, because if you just excise this part and leave this behind, patient might either have a fistula or recurrence. So it's mandatory that we identify if there is any extraocular extension, even small, and excise it. Let's get on to adults now. In adults, well-circumscribed mass, there are four main differential diagnoses. Of course, there may be many more, but the four main ones are cavernous hemangioma, Neurilemmoma, Neurofibroma, and Fibrous Histiocytoma. If you're asked in the exam what are the four differential diagnoses for a well-circumscribed lesion, you can give that in this particular order. This is in the order of frequency of occurrence. All these well-circumscribed lesions can produce either axial or abaxial proptosis depending on their location. If they're located in the intraconal area, then it is typically axial proptosis. If they are located in the intraconal area with extraconal extension, then it is predominantly axial proptosis with slight amount of displacement. If they are predominantly located in the extraconal area, then they have abaxial proptosis. If the tumors are located anterior to the equator of the eye, then they cause more displacement. If they're located posterior to the equator of the eye or in the intraconal area, they cause more proptosis than displacement. These are some of the teaching points. Now, all these patients have very mild proptosis compared to the size of the lesion. So it's been chronic, so it has grown at the expense of fat, such a large lesion producing mild proptosis. All these are examples of cavernous hemangioma, typically well circumscribed, and imaging is very characteristic, whether it is CT scan or MRI, and you can completely excise them. Another example of a well circumscribed lesion is neurofibroma. Neurofibroma mainly occurs either in the supraorbital nerve or the intraorbital nerve. Supraorbital nerve is more common. It can have it is generally extraconal if it occurs from supra or intraorbital nerve, but will have a major intraconal component. So they do have proptosis along with displacement. Very well circumscribed. You can see the nerve dipping into it. That's the nerve through from which it has grown. So you have to excise a segment of the nerve along with neurofibroma so that it doesn't grow back. This is an example of neurofibroma, which also is very well circumscribed lesion. Neurofibroma is relatively rare, and this is benign fibrous histiocytoma. Clinically, or even on CT scan, it is impossible to tell a benign fibrous histiocytoma from a neurilemmoma, but MRI characteristics are quite distinct, and benign fibrous histiocytoma can occur anywhere in the orbit, whereas neurilemmoma occurs majorly through supraorbital nerve or infraorbital nerve areas. Now, again, a different way of classifying adult proptosis is axial or abaxial. Four major causes for axial proptosis in adults in the order of their occurrence is cavernous hemangioma, lymphangioma, optic nerve glioma, and optic nerve sheath meningioma. We already saw cavernous hemangioma. I will not repeat it. Lymphangioma, this lady you have already seen, but because she has an intraconal component which is slightly larger, she has presented with what looks like axial proptosis with very mild displacement. So if you have a patient with mild axial proptosis and loss of vision, and when you look at the fundus, you find these blood vessels. These are abnormal blood vessels with optic atrophy, which appears to be secondary. There is gliosis around the disc, and these are optociliary shunt vessels. So diagnosis is now very, very characteristic. It is nothing but optic nerve sheath meningioma. There are differential diagnoses for optociliary shunt vessels, which could even be chronic optic neuritis. But if there is proptosis and if a patient has optociliary shunt vessels, then you are definitely going to put optic nerve sheath meningioma on the top of your diagnosis. Now, abaxial proptosis in adults are either lymphoproliferative lesions, Neurilemmoma, lacrimal gland tumors, or other structural tumors, exactly in that order. Lymphoproliferative lesions are more common, followed by Neurilemmoma and lacrimal gland tumors. Lymphoproliferative lesions are soft or firm to palpate, they're never hard, and this kind of mold around the eye. That is the classic description. They just surround the eye with rounded contours and they're isodense on CT scan. Some of them can have irregular margins as well. But if you're really not sure what you're dealing with in a patient like this, you should always look at the entire eye. When you lift the lid in the superior cornix, you find this fleshy pink lesion with a salmon pink color. So it's clinically a lymphoma or a lymphoproliferative lesion. This is a patient with Neurilemmoma with abaxial proptosis. And again, a Neurilemmoma of the infraorbital nerve here. You can see the lesion located in the inferior orbit, and that is the infraorbital nerve that has been taken out along with the lesion, and the eyeball is displaced upwards along with some amount of axial proptosis because it is also in the intraconal lesion, intraconal area. Now, this is an example of a supraorbital Neurilemmoma. Patient has mild proptosis because there is posterior extension, and it is mainly in the extraconal compartment that it is there, and it is arising from the supraorbital nerve, and that's a chunk of nerve that has been taken out along with the tumor, because otherwise the patients recur. This shows why they recur, because you see this is the normal caliber of the nerve, and you see the small little nodules. These are small little Neurilemmoma meta. So if you excise it flush with the nerve like that, then these remain to produce a recurrent tumor. So you have to always inspect and look at the CT scan very, very carefully, like this nodule, this one here, and this one here correspond to this and this. So you look at the MRI very carefully and aim to take out the entire lesion. They can also be bilobed. This is just to show you that if you don't excise the complete lesion, well, this could have been very small and it could grow back again. So this is how Neurilemmoma can recur. Coming to lacrimal gland tumor, this is a very classic classification, not that it holds the test of time because things have changed since it was described this way. There is 50% are epithelial and 50% are non-epithelial. In non-epithelial, mainly you have specific orbital inflammations or non-specific orbital inflammations and lymphoproliferative disorders. Lymphoproliferative disorders can be reactive, indeterminate, or benign reactive lymphoid hyperplasia or lymphoma. Non-specific or specific, you can only differentiate by doing a biopsy. So biopsy is mandatory when you talk about a lacrimal gland lesion. In epithelial lesions, you have 50% of them benign and 50% of them are malignant. Of those 50% which are malignant, adenoid cystic carcinoma is constituted by these. Rest of the 50% malignant lesions are either adenocarcinoma or adenocarcinoma X pleomorphic adenoma, or a mucoepidermoid variant of carcinoma, or infiltrations of the lacrimal gland by secondary malignancies. So basically 50% of malignant lesions are adenoid cystic carcinoma. So simply remember 50% are epithelial, 50% are non-epithelial. In epithelial, 50% are benign, 50 are malignant, and 50% of malignant are adenoid cystic carcinoma. Pleomorphic adenoma occurs in the supratemporal orbit, very well circumscribed lesion producing displacement of the eye and very gradual proptosis. Well, if it is causing indentation of the eye like this, the patient may have distortion and astigmatism related decrease in vision, because of which they may come to you. Otherwise, it lies quietly for a long time. And then treatment of choice is complete excision. You should never break the capsules of a pleomorphic adenoma, because it may then recur, and some of the recurrent lesions produce carcinoma, adenocarcinoma, X pleomorphic adenoma. So despite the presence of erosion in the bone, as you see here, you still have a good chance of complete excision. That erosion is only because of pressure-related erosion can completely excise. This is an example of, again, a pleomorphic adenoma, which has been growing a nodule. So they can actually auto-rupture their capsule and grow into very bizarre shapes and sizes if they're chronic and if they're extremely vascular, as you see here, but it's still a pleomorphic adenoma. Whereas as compared to pleomorphic adenoma, adenoid cystic carcinoma crosses the midline. Pleomorphic adenoma is generally lateral to the midline, whereas if a lesion crosses the midline, then you think of adenocarcinoma or adenoid cystic carcinoma. Once it crosses the midline, the supraorbital nerve is right there. So it is a neurotrophic tumor. So patients sometimes have a symptom of an paresthesia in the forehead or pain, referred pain, paresthesia, anesthesia of the forehead is a typical feature of adenoid cystic carcinoma. They may come to you with those manifestations. Adenoid cystic carcinoma is currently dealt with by multimodal treatment, where you do a biopsy, direct approach biopsy, not through a lip crease incision, confirm the diagnosis, confirm the cellular type, then tailor chemotherapy so that the tumor reduces in size. So this is the size of the tumor that we began with. There's a small medial extension as well around the medial rectus muscle, definitely crossing the midline. And after 3 cycles of chemotherapy, the tumor has obviously shrunken. That is when you do a complete excision with the periosteum. Along with it, that is called en bloc excision. Follow that up with stereotactic radiation and complete chemotherapy. So this is a patient with adenoid cystic carcinoma where you can see that there is gross bone erosion. So still, despite which you can excise the tumor and complete the treatment, and the bone often remodulates. Now, if a patient has variable positional or pulsatile proptosis, so this is a different class of manifestations. Patient has proptosis, but it is variable. That means when a patient is sitting down, it changes its measurement. If the patient is bending down, it is different. It is pulsatile. Then you think of vascular lesions. So like this patient has enophthalmos, that's what she has. And when you look at the inferior palpebral area, she has bluish discoloration and abnormal blood vessels. When you ask her to do Valsalva maneuver, there is obviously a lesion that is showing up. This is orbital varices. Now, there is a very nice classification of vascular lesions. I don't have time to go into the details of it, but one more lesion that can also cause pulsatile proptosis is neurofibroma with a meningoencephal. Now, this is a neurofibroma. Why does it cause meningoencephal? Because there is dysplasia of the sphenoid vein. So, if the bone is missing in that area, there is direct communication of the brain to the orbit. And when the patient, has this kind of a situation, there is pulsation of the brain that is transmitted onto the eye. So, they have pulsatile proptosis. Next class of lesions are triradiate lesions. Triradiate lesions are the ones which center in the sphenoid wing, have extension to the temporal fossa, orbit, and also intracranial. So 5 typical triradiate lesions, these are quite common by the way, are sphenoid wing meningioma, eosinophilic granuloma, osteosarcoma, Ewing's, and metastasis. Like this lady has come to you with proptosis that is evident. But at the same time, look at the temporal fossa. Temporal fossa is generally flat or concave. This is convex. So if temporal fossa is convex and if the eyeball is displaced inferiorly and medially, you expect a lesion here, that is in the sphenoid wing. And when you look at these patients on the scan, you find that there is temporal fossa extension, intracranial extension, and intraorbital extension centered around the sphenoid wing, which is the epicenter. This is very, very typical manifestation of sphenoid wing meningioma. So if you have a patient with fullness of the temporal fossa, then you should suspect in an elderly individual sphenoid wing meningioma. In a younger individual, the situation is different. If it is mainly osteolytic lesion with some reactive changes around the bone, and the lesion is still centered in the sphenoid wing with orbital, temporal fossa, and intracranial extension, you suspect eosinophilic granuloma. This was a patient who was a retinoblastoma survivor who also presented with a triradiate lesion. Then that's the second malignant neoplasm, which is osteosarcoma. Very rare triradiate lesions can be Ewing sarcoma. You can see this sundry appearance of the bone and a lesion centered in the sphenoid wing. Metastasis can also present on the sphenoid, especially metastasis to the bone, such as prostate, can present as triradiate lesion. This is involving the sphenoid, orbital component, a small intracranial component, and not much of extraorbital component. One more lesion where similar presentation is there is plasmacytoma. Again, you see that sphenoid wing is destroyed, a larger orbital component, a smaller intracranial component, and a medium-sized extraorbital or temporal fossa component. You can see the temporal fossa component here infiltrating the temporalis muscle. That's a very typical plasmacytoma. And if you do a CT scan in this patient, you find the typical punched out appearance. So that is about the stepwise approach to the orbit. I'll see if Lakshmi has returned. Lakshmi, have you come back?
Yes, Santosh, I've come back.
Yeah, can you go ahead?
No, please,
Yeah, please go ahead.
Go ahead. Please go ahead.
Well, I just have treatment now. I mean, I've finished with the series of.
No, in any of these cases where you you were anticipating something else and, it turned out to be, please highlight us. For instance, I have a question for you.
Yeah.
In these triradiate lesions,
Mhm.
the classical teaching is neuroblastoma, right? When you see the typical sun ray appearance, it's a neuroblastoma.
Yeah.
But you have mentioned
Correct.
in your...
Neuroblastoma in children.
Pardon?
In children, correct. In children, that is the most
Yes.
common lesion.
Now,
Neuroblastoma
how
and
does...
neuroblastoma.
Correct. How does it... sorry, other than neuroblastoma, what else did you say?
Nephroblastoma, Wilms tumor, metastatic Wilms
Yeah.
tumor.
But for
So I will show you
nephroblastoma,
that.
you need an ultrasound of the abdomen, no, to confirm the...
Correct. Absolutely. Absolutely.
Correct.
Absolutely.
And the next thing is,
So,
why does Ewing sarcoma cause this kind of an appearance there? So is histopathologically there is some kind of a similarity? Because
yeah,
I have
Ewing
not
sarcoma,
come across case of sun ray appearance with Ewing's.
yeah, it has, it's a round cell tumor and it occurs in the sphenoid wing. And yeah, so it has a triradiate conflict. This is the metastatic Wilms tumor. Wilms tumor, again, so you can see the temporal fossa fullness. And this patient also had intracranial extension to a CT scan. It is bilateral. And when the exactly similar situation occurs, if there is periocular hemorrhage, raccoon eye sign, then that is neuroblastoma. So exactly same except for hemorrhage. And you can see a very typical triradiate lesion, temporal fossa, intracranial, and orbital extension.
But it need not be so bilaterally so typical, no? It can be sometimes it can even be more on one side than the other.
Absolutely. It can be asymmetrical, it can be unilateral, but these are just classic examples where there is bilateral, so people should never miss if they see something like this. The child has to go to a pediatric oncologist on the same day. You cannot even miss that.
Would you want to do a biopsy to confirm these cases?
Well,
would your oncologist suggest? Because in those days, they used to insist.
Yeah.
Would you do it?
Yeah, if they ask for it, you do a biopsy. Otherwise, if they simply want to take over, if they want to go ahead and do biopsy from the primary lesion, then they can. Orbit is more convenient to do a biopsy. So if they want a clinical confirmation, we can definitely do a biopsy. And it's easily accessible lesion. So since it's so superficial, you can easily do a biopsy. But of course, in neuroblastoma, I've had situations where bleeding is excessive when you biopsy. So to be very careful because it's a highly vascular tumor. So you might still want to do biopsy with the fine needle aspiration cytology than do an open biopsy.
Santosh, can we just go to some of your means not so common tumors where you can just explain a little more? Because I have now, I'll take some time. If there are questions, I can highlight. I may take some time to bring in other slides. But so I think because I missed some of them, some important pertinent questions. Now, this is typically a round cell tumor, right?
Yeah.
Pathologically.
Yes, that's right. So I'll just go over. I mean, how much time do we have? I think we have about 15 minutes. So
15 minutes?
Covered.
Okay.
Yeah. So we'll go ahead with some. Basically, what I was trying to say is that when you have diagnosed them.
I have one curious question in that previous case, that neuroblastoma case. If you have to do a biopsy, would you do it in the intratemporal fossa or would you do a lateral orbital incision, anterior orbital or lateral orbital incision?
I would do a small lateral incision and go to the temporal lesion, then get into the orbit, because if it bleeds, temporal area is safer than having bleeding in the orbit.
Point taken.
So when we have this clinical radiological confirmation or suspicion of diagnosis, do we always do surgery? The answer is no. We don't always do surgery. There are situations when you say clear no to surgery. There are situations when you say clear yes to surgery. And sometimes it is the gray zone. These are all no to surgery, but unless the oncologist insists, then you don't want to do biopsy. Like this patient I earlier showed of granulocytic sarcoma, where there is subconjunctival hemorrhage, rod spots, and peripheral blood smear being positive, you never want to do biopsy because we already know that it is leukemia. Whereas in a patient with a triradiate lesion with punched out appearance of the bone, but patient does not have multiple myeloma, so the radiologist or the oncologist wants a confirmation of diagnosis, then you can do biopsy. Even a fine needle aspiration cytology is good enough in these patients. And if fine needle aspiration cytology does not yield enough material, you can go for an open biopsy. Then what are the non-surgical approaches? There are certain situations where you want to avoid surgery. Like this patient who's an airline pilot, whose main concern is that he was failed in the medical exam. He hardly has any abnormality. And if you notice it very carefully, he may have mild proptosis of the right eye. But why is that so? Because he has a lesion in the orbital apex, which is jutting into the superior orbital fissure area. It is kind of pear-shaped lesion posterior in the orbit, and he's an airline pilot and he does not know any other work. So what if cavernous and hemangioma surgeons delight, Lakshmi will tell you, but if you meddle in the superior orbital fissure area, even if you're very, very gentle, there is always a reason to worry because you might cause some hemorrhage or some stretch over the optic nerve or some extraocular muscle or any of the nerves passing through that area. So patients may have diplopia, and this patient's occupation being flying, so obviously you cannot afford to have diplopia. His visual field was also affected. So we chose to do a non-surgical approach here where we gave stereotactic radiation. And you can see the size of the lesion has considerably shrunk down. So at least for the next 5-6 years, we thought he was good to go. And in fact, he's pulling on for 8 years now. There is absolutely no change in the size of the lesion, and his visual fields have remained normal. He's back to flying. So these are the situations where you don't want to do surgery, especially if the lesion is very posterior in the orbit, very close to the superior orbital fissure. This
So
is
I have
from
a
the
question.
literature.
Was
Yeah,
this a hemangioma or you think it was a meningioma?
it was a cavernous hemangioma.
Because of the
MRI.
severe vascularity which you saw. Because
Yeah.
sometimes meningiomas also can be pretty vascular.
Yeah, they can. But MRI, flow voids and all, they are very confident of diagnosing cavernous hemangioma in MRI.
Okay. So this was 7-year follow-up, it shrank so much, or after how many days did it shrink to that size?
6 months,
Because it's
six
almost like
months,
70% shrinkage, right?
it is definitely more than that. So it started shrinking at about 3 months of following
Oh, wow.
radiation. And by 6 months, he had partial resolution of visual fields. And obviously, it has remained stable for the last 5 years. So by 2 years, most of the shrinkage was complete. After that, he was absolutely stable. He has never increased in size and it has very little vascularity. This is from the literature, actually. You can see how dramatic visual field has improved in this patient. This is published case in the literature, Ismailis group, and you can see that the small lesion has shrunk further smaller, and the optic nerve, pressure over the optic nerve has gone away. So they did a volumetric analysis and they found that there was 76% volume reduction in this patient. So this is possible. So you don't have to do surgery in all patients. So in fact, Moritz went on to say that beware of pear-shaped lesions. If there's a posterior orbital clearing like this, then that is very safe to operate, something that looks like an apple. But if it is pear-shaped like this with the snout getting into the superior orbital fissure, then try alternative methods. And if you're not sure radiologically as to what the diagnosis is, then only venture on to do biopsy, etc. But if your radiologist is quite comfortable with the diagnosis, then you can try alternative measures.
So
Now,
what do you think stereotactic, I'll interrupt.
sure.
Stereotactic, was it, you said here it's gamma knife. Now, some of them are saying cyber is better than gamma. What has been your personal experience on this cyber and gamma? Because what I'm told is it's mainly an interplay in the LINAC. That's what I mentioned in my talk. But what do
Absolutely.
you think is better? Especially, let's start with
I
meningioma, where we really these days not doing a biopsy, straight away subjecting the patient. What is your choice? Is it gamma knife or cyber knife?
Cyber knife, because we can't afford to have both. So we have what we have to use. Cyber knife
Correct.
is what is there at Apollo. So we use
Okay,
that and
fine.
happy with the results. And even in the literature, it is comparable. So you really don't have to worry about whether they use cyber knife or gamma knife, because finally they're going to give you results. And results are quite satisfactory. So comparable. So as an ocular oncologist, you don't have to worry about what modality are they going to use as long as they use one of these.
Are the treatment rates comparable between both? Both are equally expensive?
Both. Yeah, treatment rates are, it depends on the facility, but CyberKnife is slightly more expensive in some facilities.
Because I also recently got a patient treated in Apollo Chennai. It was done very well, just about 5 sittings. And we have to see the long term, because right now we're not appreciating too much of shrinkage. It was a meningioma, but
Right.
definitely the disc edema has come down and the vision is preserved. So, but the other patient
In
which I
meningioma, it
showed
takes
was
a long
cyberknife.
time. Meningioma takes a long time to reduce in size. The first thing to go away is vascularity, and they might be at the most 30-40% reduction in the size of the tumor. But what happens ultimately is that they remain stable for a long time, and that's exactly what you want. Even if the patient loses slight vision over 5, 10, 15 years, they're acceptable with it rather than losing vision immediately because of surgery. So radiation is definitely better than surgical debulking and stuff.
So the important pearl from you is you have stopped doing biopsy for a meningioma?
Biopsy we do to know the WHO grading. And then because our
But if
radiation
it's a posteriorly located, like this is pear-shaped lesion, beware of the
located, you cannot do biopsy unless by CT guided FNAC. Otherwise, if it's accessible, even accessible from the lateral approach or deep lateral orbitotomy, insistence is on biopsy because we need to know what is the grade of the lesion so that they can tailor the dose of radiation accordingly. If it is a very low grade tumor, they don't extend radiation beyond 4,500 centigrade. But if it's a high grade lesion, because we don't know the timeline, patient would have come to you at a particular time, would have done scan. If you serially follow them up, then you know what is the aggressiveness of the lesion, how has it been growing. So if it's a rapidly growing lesion, obviously there is high cellularity, and then the dose of radiation is also slightly higher. They go on up to 6,000 centigrade if it's depending on the cell type. So they would want to know. If you cannot do that because of logistic reasons, if the lesion is very posterior, then they accept it as a fait accompli and then treat to the best of their ability. If you can do a biopsy,
explain the risk of vision loss due to the biopsy itself, or you just go see the lesion and take out a small portion and come out?
We always take a small portion. We don't extensively, disturb it. Very small portion is all that is required.
And you have not noted any vision loss because of that small incisional biopsy?
Not because of biopsy. No. Not because of biopsy. Nobody has lost vision. Patients can lose vision in orbital surgery. It's like 1 in 100 cases reported in the literature, 1 in 1,000 patients generally. So, but not because of.
Because earlier on, I was 1 or 2 cases of my meningioma, they lost vision because there we were attempting debulking in addition. That time we didn't have, this is in the late 90s, we didn't have any cyber gamma knife at that time. But later on, our last 4 cases I have managed without biopsy itself. Anyway, it will be interesting to see. We'll have to talk about that at another time. Very nice. Thanks. Please finish off anything more you have to say, please. How many more minutes we have?
We have 5-7 minutes, I think.
Session and the next 10 minutes.
Yeah.
10 minutes. Any other slide of yours, Santosh, where you have not injections? No. That's good. Bleomycin you have.
Yeah, bleomycin and picibanil. So either of which is good. Picibanil is difficult to obtain. It's a Japanese drug which has to be imported. So basically you use that in patients who have no functional problem, yet the lesion is extensive. It is all around the optic nerve. It's around the lateral rectus, medial rectus, superior rectus LPS complex, lacrimal gland, where surgical debulking is fraught with complications. So there, if the patient wants cosmesis and patient wants relief from multiple recurrent bleedings that she experiences, then injection would be a good option. Now we know that bleomycin can be toxic to the optic nerve, so you don't inject a large volume, especially if it is a macrocystic lesion. You can inject larger volume. Whatever you aspirate, half the amount can be injected. But if it's a microcystic lesion, then I restrict my injection to 1 cc of bleomycin at one point in time. We can always go back and inject more. And if it is a macrocystic lesion, then resolution is very good. If it's microcystic, resolution is low. This patient had a microcystic lesion, yet you can see how beautifully she has resolved. So this is one of the better results, but not all patients resolve as nicely as this. You may need 2 or 3
injections. It's excision plus bleo or only bleo?
Only bleomycin. Only bleomycin.
Bleo. Okay. And what is the youngest age you have given bleomycin?
Bleomycin I've given in a 6-month-old child where there was where there was a chocolate cyst. After aspiration of the chocolate cyst, injection was given.
So the same dose, but or you give even lesser for a child.
Not required. You aspirate. See, suppose the aspirate is 3 cc. I give half of it.
Okay.
Volume.
Give half the volume of what you have aspirated.
Aspirate. Correct.
And generally, chocolate cyst will burst and it will let out all the chocolate colored blood. Do you try to take out a little bit of the wall as well?
No, when you do a aspiration, it is only a blind aspiration or ultrasound guided or CT guided aspiration. You don't open it at all.
Okay.
So you aspirate and then with the same needle, with the needle held in position, change the syringe to bleomycin and inject within the same cavity. You don't come out at all. So the drug directly gets into the wall of the chocolate cyst. So you don't open at all in such situation.
I have a curious question
like
now.
this is the one.
Okay. How often do you do FNAC now? Because earlier on we were doing so many of those FNACs.
Hardly any. Only for lymph nodes we do it. This is what I was showing. You see this? There is no incision at all. Correct? This is the no incision at all. Absolutely no incision.
Okay.
And we aspirated so much of blood. Earlier, this is the oldest slide, we used to give equal volume. Now we give just half of it. Equal volume because that is what the standard teaching is. Because even if you give half of it within a couple of injections, it resolves. So I think restricting the volume is also important so that you can avoid complications. This was a child where somebody else had biopsied and it had re-bled. And this was the residual. And you can see one injection, almost everything is gone except that in the posterior orbit. And the child has a reasonable amount of cosmetic. So it works very well. Bleomycin and picibanil both work very well. And depending on what drug that is available to you. This was a patient where we did not know what the diagnosis was. Radiologist was not very keen to say, confirm it was lymphangioma. It was an acute proptosis in a child who never had such a history earlier. So we had to do an open biopsy here. And this is where I could take out part of the wall that as you are describing. And obviously, when you do that and inject bleomycin, you have to be careful because the drug can extravasate into the orbit. Yet that is the only option that we have because it's a larger diffuse lesion. And that was given. And this was a patient where you're asking whether debulking is done. Yes, this patient was debulked. And for the residual, bleomycin was given. So you can use a permeation and combination. This patient, nothing was done except aspiration and bleomycin. So you can use a permutation and combination. You simply don't have to restrict yourself to one modality depending on whatever is the situation. You can either give injection, do debulking and give injection, or just do debulking.
Yeah, I have a question to Santosh.
Oh, you're there, Kasturi. How come?
It's fantastic talk. I have listened to both Lakshmi ma'am and your talk. Like it's so engrossing. I couldn't leave.
Hey, if you knew you were here, we would have made you talk as well.
No, Santosh, it's too good. Learn so many. It's so good learning points. Bleomycin, in a child, do you give half the volume? Do you keep the dose of 0.5 per kg body weight? Like how?
No. It is always less than that. It's always less than that. So I just restrict myself to half the aspirate.
Okay.
It is always, even if you do 0.5 international units per kg body weight, it is always less than what you ever give. So, you generally give about 2-3 cc. So it's always underdosed. Never a systemic problem.
Santosh, I started using picibanil sometime in 97 or 98. After about 2001 or 2, gave up on it because it was not working. And I'm so happy to note you're saying that it is working well. Like we had only a 50-50 result. And I tried, then I went back to Tricot all these years. In the last 6-7 years, I've been using bleomycin. Pretty happy with the outcome.
Bleomycin is very good.
You definitely feel it is still 50-50 because what you say will be very important because I may be tempted to go back and use picibanil. Otherwise, I had written it off for good. Remember Dr. Ogita, he came for our meeting in 99. He was the one who used it extensively for cystic hygromas and lymphangiomas elsewhere. In fact, he passed away a few years back, the Japanese doctor, and he has an Ogita Foundation for lymphangiomas. But when he saw some of our orbital lymphangiomas, he almost gave up. He said, oh, no, I don't think I'll use picibanil for this. That's what Dr. Ogita told us when he came for our meeting in 99. But honestly, like, are you really happy with picibanil and where are you getting it from? That I'll ask you.
I'm happy because
not in the forum.
No, they give it free of charge. All you have to bear is the courier charges. It comes from Japan. The only catch here is that you have to get approval from the Drug Control Authority of India, and it is patient-wise approval. So we have to collect the Aadhaar card and identity data of the documents of the patient, and when the drug arrives in the customs, patient representative has to go. That is, one of our hospital staff has to go and collect it. So that way it is logistically difficult, but it is absolutely free by the PC Foundation. Only commitment that we have is to provide them with the data, which is okay to provide. So in, before COVID, it was easy. Now that particular, it stopped. And by the way, from what they were doing earlier, they have re-evolved the medicine. It's a different formulation now, I believe, which works. Yeah, it works as good as bleomycin, but the only advantage of Pisibanil, I feel, is that there is zero inflammation. So you should not be worried about
true. That I 100% agree with you.
So intracorneal lesions, if you have in a patient with 20/20 N6 vision, then definitely my heart would be kind of beating faster if I give bleomycin. But Pisibanil, I would not be worried.
Something interesting I'd like to share, ma'am. I was also there in the 1999 meeting. But
yes, you were there. You were very much there.
Dr. Cyclin, you know what happened? Like in my initial days when the patient used to come with this lymphangioma, for some reason, for MGD or something, I used to give Cyclin long time back, and I could see there was some regression of the lesion. The oral doxycycline I was giving.
For how many days? Generally, we give it for 21 days for MGD.
A month I used to give. That I used to notice, but I never took it very sincerely. But I feel that even oral doxycycline really has a role. Like now the people are also giving injectables, right?
Injectable doxycycline is done anyway. That is accepted.
But I think, I don't know. I have those patients, at least 4 or 5 patients I remember just for MGD I have given who were also having lymphangioma, and it had really shrunk the lesion to quite a good extent.
And with bleomycin, do you both give IV steroids soon after the injection to bring down the violent reaction due to bleomycin? Because oral steroids alone may not help and sometimes the reaction is noted on the following day. What do you do? Kasturi,
so I see them on the following day. I do it as an OPD procedure. I don't generally give, unless I am injected intracorneally, I don't give steroids. But when I see them on the following day, if they have developed inflammation severe, then we give one injection of intravenous steroids. It is a good idea not to give because you want to induce sclerosis, and if you give steroids, the effect of sclerosing agent will be much less. So you don't want to give long-term steroids. One injection is okay.
Yes, ma'am, same. I never give steroid, but 2 patients had compartment syndrome. So those 2 patients, 2 of my patients, those 2 patients, I gave IVMP only to prevent him, going for blindness or affecting the optic nerve.
All right. So sorry to intervene.
Thank you so much. Thank you, Kasturi. Thank you, Santosh. Thank you, Mr. Lakani.
Thank you so much.
Thank you, Dr. Lakshmi. I hope you all had a
good
session. And I would like to also thank Dr. Santosh. And I think Dr. Santosh is going to stay along with us for the next session. Sure. So thank you for your screen time. Thank you for your virtual time. And we'll see you back in the next session. Thank you.
Thank you very much. Thank you once again, Santosh.